This video is about hydrocephalus. We're only going to cover non-communicative or obstructive. Same thing, hydrocephalus, pathophysiology, and treatment. There's two types, congenital or acquired. Congenital usually caused by toxoplasmosis, rubella, or mumps if the mom did not get the vaccine, or meningitis can be seen in pediatric hydrocephalus. Now, the newborn infant can handle hydrocephalus a little better because they have fontanelles, so that's why you see them with the big heads when an infant with newborn hydrocephalus. In adults, it's more usually like blunt trauma, brain tumors, or cysts, or intracranial bleeds. If it is a bacteria, usually meningitis. But you see these lateral ventricles with the pressure because somewhere there is a blockage. You can have a blockage in the arachnoid granulations. You can have a stenotic aqueduct of Sylvius. You can have a bleed. You can have a bleed in the third ventricle that blocks the foramen of Monro and foramen of Luschke, which is easy to remember because Luschke is lateral and M is medial. So Monro medial, but so the CSF drains into the cisterns, which become the arachnoid space, but there's two cisterns. Well, it drains into the medullary cerebellar cistern naturally if you don't have hydrocephalus. But if you do, it doesn't have a way to drain. And it gets really bad because the brain is a box. And if it starts, meaning it doesn't compress or expand, you got brain parenchyma, blood, and CSF fluid. And the skull doesn't move. So if the intracranial pressure rises by a tumor growth or a subdural hematoma or increased CSF, that's all going to put pressure on the cerebrum and can cause damage. So these are just, you got your subtentorial herniations. Here's a subphalicine herniations. They're all bad, except number 4 really is can be controlled by the neurosurgeon because it's a herniation through the burr hole during surgery. So it's bad. You want to avoid it, but it may not cause as much damage as all these other ones. Okay. So, I already said all of this. I just put a skull there because to know it's bad. So there's the treatment options. There's 3 major procedures, but first, if you're lucky, the blockage clears and no treatment is required. If you're lucky enough that spinal taps drain excess CSF and clear obstruction, no further treatment is needed. Because the obstruction, let's say if it's due to a blood clot in the foramen of Monro and Luschke or something, that could clear up. But if it's a stenotic aqueduct of Sylvius, that may not clear because that aqueduct is going to stay stenotic. I don't see why it would expand. I mean, you can put a surgical shunt in it, but it's treated better with EVT because shunt can get infected and it only lasts 1 to 2 years, whereas EVT is more of a permanent one. 75% of patients have relief. Even after 15 years, they're living normal quality of life. So the dangers of the ventricular shunt is the float. So the shunt can clog itself, and then you just get symptoms of hydrocephalus again, because it's not the cath isn't going into the peritoneal cavity where the CSF can be absorbed, and you can have, you may have to adjust the flow rate if it's over draining the CSF. You run into a lot of problems. You can get a subdural hematoma, I think. You can get a internal bleeding. You can get it can be deadly if you over drain it. Is bad. Okay, so if you have obstructive hydrocephalus and a ventricular shunt, the neurosurgeon is going to take care of the hydrocephalus before removing any mass, because high ICP is the bane of neurosurgical anesthesia, but we won't talk about it here. So the very easy way to understand this is you got the choroid plexus is in the lateral ventricles and the third ventricles, and it produces CSF, and the CSF has to be drained. And this aqueduct of Sylvius here, if it's stenotic, that can be obstructive. If there's a hemorrhage here covering the median aperture, foramen of Magenta, the lateral aperture is in the fourth ventricle. I apologize, fourth ventricle. The third ventricle is here. The fourth ventricle is here. So the yep, that's pretty much it. And so if you get blood in your spinal cord somehow, I don't know how, but that's how you can block it. You see the arachnoid granulations right here. This is the worst place to have the obstruction, because it requires a VP shunt, which requires replacement every 8 to 10 years, and it's, reduces quality of life. But this isn't where the CSF exits. The CSF exits into the cerebellum medullary cistern. And then it goes through the arachnoid space, and then it reaches the arachnoid granulations, and then it drains into the venous system of the brain, as depicted here, until it eventually goes to the sigmoid sinus and superior vena cava. You got the basal vein here. You got so it drains to the superior sagittal sinus for a good reason, because it gives it a nice direct flow out into the sigmoid sinus. And these tributaries are just for getting your normal brain deoxygenated blood back. So you might have some CSF flow this way or something, but usually it'll go like this through this straight. Well, no, not the straight signs, but you get the idea. That's all there is to know about that. Okay, so I circled in red because if you're using a VP shunt and the flow is set to over drain the CSF, it can be dooming because you could have mild symptoms which could confuse the patient and the surgeon, and it may go unnoticed, delaying vital treatment. Although you'd think you'd notice an internal bleed, but apparently in the literature it says that and that's the worst. Cath may be too short, it may be lengthened. If it's too little, you can just again change the flow rate. And under drainage is not as bad. This is just so you know, there is a ventricular atrial shunt. Infants get it. I don't know if it's done much. I don't see the point of involving a second major organ when you already got problems with one major organ. The only thing I can see, I suppose the catheter is shorter and goes directly into the right atrium, drains directly into the right atrium, and there's the possibility of less risk of infection because the foreign body is shorter. And it doesn't have to go through the venous system of the skull and drain into the peritoneal cavity where it's absorbed. So I could see this, but and actually this is probably done as a cure, and that's why it's only done in children, because you drain the CSF if the cause is obstruction at the foramen of Luschka and foramen of Megandium. So I already said all of this. One thing, it's called arachnoiditis when you have a blockage. It's very difficult to see post-mortem at autopsy, but hemorrhages are easy to locate. So if you had over drainage and got an internal hemorrhage, the forensic pathologist can be sure that that could be on the top of his differential for cause of death. Failure of the catheter flow rate or error in setting the flow rate too high. So just because you can't see arachnoiditis grossly or microscopically, we know that it has to be that, because that's we see arachnoid granulations. Here you see calcifications. You can visualize it on CT actually, but not post-mortem grossly. So you can see where the obstruction is. Here you see it's in the arachnoid granulations. This is an adult. External masses can cause so these are just external masses. So you can see in the fourth ventricle, a mass can block the foramen of Mengele and Luschka, such as medulloblastomas, astrocytomas, Dandy Walker cysts. So you can see a cyst could block the initial flow. The cerebral aqueduct could fork, stenose, or periaqueducal gliomas. I've never even heard of that type of cancer, but or subependymal gliosis. What is gliosis? Cis means inflammation, so inflammation of the glia makes it stenotic. Pineal tumor would block the third ventricle, and if you block the third ventricle, you need to do an EVT to cure, pretty much. The bacteria, if it blocks your arachnoid granulations, it's usually a venous thrombus or post-meningitic, but usually this is caused by bacteria, and it's the worst prognosis because you need a VP shunt. Foramen of Monro, gliosis, keloid cyst. You can get a cyst in the foramen of Monro, and that could cause stenosis of the ventricular system. So that's neurosurgical level. Here you can see, so remember white, hypoopacity means like calcium bone or something, but you know it's a blockage. Black is air on CT, T1. No, CT scan, sorry. So here you see some, maybe, I don't know if it's a calcification, could be anything that the X-ray can't penetrate. But here what it's pointing to is, let's see here, what kind of blockage is this? To be sure, you got the cerebellum there, but it's weird I don't see a pons. Oh, this is, I think this is a Dandy Walker malformation, because I don't know if it's type 1 or type 2, but you can see it herniating a little bit past the foramen magnum. So I think this is Dandy Walker syndrome, which would cause yep, exactly. You can't really see the pons in that. It will cause blockage at the fourth ventricle. So this is, I'm going to say it's Dandy Walker syndrome. Someone can correct me if I'm wrong. If a pinealoma causes the blockage, you do an ETV shunt and resection. So the risks of the VP shunt is infection, bowel perforation, shunt migration, and yeah, infection. So this is why EVT is used. the other alternative to VP shunt. So, you know, if you know that it's arachnoid granulations calcified or blocked, you wouldn't do an external ventricular shunt. This is where you go to the ICU for 3 weeks, and it's similar to a you know, you insert, you put a small burr hole, a catheter, and you drain CSF at a certain flow rate. And then what they do at the end of 3 weeks is apply more pressure to see if the blockage has cleared, and they know that because the CSF will be flowing out and the intracranial pressure won't rise. So you could try that. It actually works in 80% of patients. And I'm going to assume that's if the blockage is in the fourth ventricle. I don't see why you would do this if it was arachnoid or cerebral aqueductal stenosis. Because the worst is the arachnoid granulations, because I mean, it's just, you can't just pop them open and make an ostomy, really. Or there's so many of them that you can't, like, repair them. Stenosis, so ETV, which I just said. So here's a visualization of ETVs is a external third ventriculostomy, and it's called third ventriculostomy because it creates a stoma at the base of the third ventricle, anterior, and creates a drainage port into the inferior pontine cistern, which then goes through the arachnoid space and drains through the non-obstructive arachnoid granulations. So here you see the ostomy has been made. You can see the basilar artery there. So this is the base of the third ventricle, and the CSF can flow out into the arachnoid space. This is, and here is the video.
Which should be around 4 millimeters in diameter. Minor hemorrhage from the edge of the ventriculostomy stops after a brief irrigation period. After performing the ventriculostomy, the ventricular scope is removed and the 30-degree endoscope is inserted for inspection of the prepontine system. One can identify the basilar artery with its branches, which indicates that sufficient communication to the subarachnoid space has been created. Following successful ventriculostomy, the endoscope sheath is pulled out of the foramen of Monroe under endoscopic visual control. One can see that the plexus, fornix, and veins are undamaged. The endoscope is also removed from the cortical puncture channel under endoscopic visual control in order to be able to recognize hemorrhaging from the ependymal veins or in the cortical puncture channel.
So that was that. That's how they make the ostomy. So the ventriculus the ventricular scope is placed, and goes through the brain, through the foramen of Monro into the third ventricle, and then it creates a stoma to drain it into here, the inferior pontine cistern. Moral of the story, acquired hydrocephalus, look out for cysts, benign and malignant intracranial tumors in adults. Perform MRI to locate the blockage and rule out cancer, intracerebral hemorrhages to determine best treatment plan. Basically, you locate the blockage. You can try a few things to see if it goes away on its own. If it doesn't, you can try the 3-week ICU stay. You can try the ETV. Well, you do the ETV if it's due to aqueductal stenosis, or the VP shunt if it's due to arachnoid villi calcification or bacterial plugging. As much as I say it, it's not horribly bad. Shunts replaced every 10 years. The pretty much anxiety of infection or shunt failure can cause the patient psychological distress. The first 3 months is the highest risk for the shunt to fail, and after that, it's unlikely to fail for 8 to 10 years. So considering the severity of obstructive hydrocephalus, the psychological distress is disproportionate to the treatment with the VP shunt. Thank you for watching. I hope you enjoyed it, and have a good day.